Hello, and welcome to the cardiovascular accident lecture or stroke. So we are going to talk about that today. All right, pathophysiology. There are two types of stroke. A stroke in itself is a cardiovascular accident. That's the real name for it. And it occurs when the blood supply is blocked by a clot or when a blood vessel busts and causes bleeding in the brain. The two types of stroke. One is ischemic, and that is where there is a blood clot blocking the blood flow. So there's a focal point of injury. There's one exact location where the clot is. It does not progress. If TPA is given within 6 hours, that's the medication that is responsible for dissolving a blood clot, then it can dissolve and the symptoms will most likely be significantly less, could resolve themselves. There may not be as much lasting damage, but it has to be given within 6 hours of symptom onset. So an ischemic stroke, blood clot, that's when TPA can be given, and the TPA dissolves the blood clot and allows the blood to freely flow back into the vessel and give oxygen to that part of the brain to keep it from dying. Typically, an ischemic stroke occurs when the blood pressure is lower, like at night when somebody's laying down and sleeping, because then the blood pressure is what's allowing the clot to travel through the bloodstream. And when the blood pressure drops a little bit, it's not pushing it through as hard. And so then it gets stuck in a larger artery and doesn't allow blood to pass. However, what sets you up for that possibility is high blood pressure and cholesterol over time. So cholesterol builds up on the inside of your arteries and thins the arteries, and then high blood pressure can cause damage to the arteries and make you more likely for this to happen. And so that's what causes the stenosis, the narrowing of the arteries for the clot to get stuck in. That's the ischemic stroke. With a hemorrhagic stroke, it's actually a brain bleed. So a blood vessel ruptures and the blood goes into that area of the brain. It's a diffuse injury, a larger site. Patient is unstable until they get the bleed to stop, and it could cause them to die if the bleed does not stop. If TPA were to be given for this type of stroke, they would die because it's a blood thinner in order to break up the clot. And if already you have a bleed, the blood thinner is going to make the bleed worse and not be able to clot and stop, and would actually probably cause death. It would definitely make it much worse and harder to stop, but most likely it would kill the patient. So it's very important to know what is causing the stroke and to know it quickly in order to stop the bleed or stop the clot from occluding the vessel and open up the area to good blood flow again. This type of stroke, a hemorrhagic stroke, occurs when the blood pressure is high. It's so high that it busts the blood vessel. So this would be more during the daytime while you're doing activities, and with chronic high blood pressure as well. Clinical presentation. The presentation of a stroke is highly related to where the blood is. So like whether the blood is bleeding into an area or blocked from an area, that's the area that's going to be affected. So whether it's on the right side or the left, and which lobe is affected based on which artery is occluded or which artery busts. So left brain versus right brain, back to our neuro anatomy and neurophysiology that we studied in our first lecture. The left hemisphere, if it is damaged, it typically causes right hemiparesis or hemiplegia. So the left part of the brain would cause damage to the right side of the face and the right side of the body. But the additional things that would cause could be apraxia, which is like poor motor planning, motor control, which it would include speech, creation of speech language, coordination of movement, things like that. Other speech deficits, remember left language, most of our language and ability to create creative thoughts and speech comes from the left portion of the brain. Memory impairments, perseveration, that's when you're kind of stuck on one thing and you're doing it over and over. Poor initiation, starting the movement, processing, hearing directions and following those, and sequencing tasks, so putting things together in a usable, functional way. Whereas with the right hemisphere, if the right hemisphere is affected, the left side of the face and the left side of the body may be affected. And additional things, they would have poor judgment, poor safety awareness, denial of disability. That's a big one. If they're not aware of their deficits, they're a lot more unsafe, likely to jump up and start walking or do things that their body cannot do and hurt themselves. Disturbance of body image, particularly what's what, recognizing their own body parts, but also midline. They might be leaning towards one side and it feels like they're sitting upright. Irritability, lethargy, and then unrealistic expectations. So more of the impulsive people who aren't aware of their deficits would be a right hemisphere stroke. Next, we're going to look at the impact of strokes based on which artery is affected. If the anterior cerebral artery is affected, so that's going to be the yellow portion of this brain, and pay close attention to what is innervated by that area. So if you look, there's like the foot and leg, and then as you go around, it's torso, hand, face. So primarily the leg, the lower extremity, is most affected with the anterior cerebral artery based on what portion of the body it supplies, as far as your somatosensory cortex and motor cortex. And then, so the areas of the brain that are damaged, I'll read over those, but you don't have to like memorize them for this class, but it's medial, frontal, and parietal lobes, basal ganglia, anterior fornix, anterior corpus callosum. So remember, the corpus callosum connects the two sides of the brain. So by manual tasks, doing things to coordinate movements across the two sides are going to be difficult with a stroke in that region. So some of the symptoms, so contralateral hemiparesis. That's weakness on one side of the body. So let's say they have it on the left, the right side would be weak, but with an anterior cerebral artery, it's going to affect their legs more so than their arms. Urinary incontinence, apraxia, let's see what I wanted to say. Okay. Including difficulty with initiation of movement and by manual task. Abulia, which is a low willpower, a low slowness, delay, difficulty initiating movements. And then contralateral grasp reflex and sucking reflex. So those infantile reflexes that we learned last week may reintegrate. They may pop up again. And so you put something in their hand and they grasp it. One of the bad things about that is if there's any weakness or spasticity in the arm, sometimes in order to get them in a good position, they'll put a brace on their hand, but the brace touching their palm will cause them to constantly try and grasp. So it might make the spasticity worse. So just be aware of that. Now with the anterior cerebral artery, if the circle of Willis is intact, remember that's this portion that kind of creates a big circle of blood flow in the brain, they may not even show any symptoms. So the anterior cerebral artery is the very top portion up here where the horn of the little man would be. And if the circle of Willis is intact, blood flow is getting everywhere else. And so other arteries could take over and still perfuse the same area. And so that you may not even notice the deficit. With the posterior cerebral artery stroke, the areas that are affected, again, you don't have to memorize these, are the occipital lobe, medial and inferior temporal lobe, upper brainstem, midbrain, and posterior diencephalon, including the thalamus. So in these pictures, this kind of brown portion on the back of the brain is affected. That's the posterior cerebral artery that feeds and supplies the blood supply for that. And then also the blue portion of this brain image. So the yellow was the anterior cerebral artery, the red is the middle cerebral artery, the blue is the posterior cerebral artery. Same with this picture, the blue is the posterior cerebral artery, red is middle, yellow is anterior. Okay, so some of the signs and symptoms. Hemianesthesia, so that is contralateral sensory loss. So they may still have the motor systems intact, but decreased or absent sensation, unable to feel on that side, at least feel the normal sensations that they should feel. The other thing that goes along with that lack of sensation or change in sensation is called central thalamic pain. So central thalamic pain is a hypersensitivity, burning, tingling pain in response to normal stimuli. It could just be a change in temperature. It could even be emotional stress on the body. Their body responds to it by telling them they're in pain. Any light touch would be painful. So it's basically pain, could be all the time, could be only during stimulus, but it could even be to the stimulus of their clothes touching their skin. It doesn't have to be anything big that we would feel or notice, and that causes pain. So that can be really difficult for the patient to deal with. Homonymous hemianopsia, that is a visual field cut where a portion of both sides of the eyes is not being interpreted by the brain. So the eyes work, but the stimulus, once it gets to the brain, is not interpreted. So it basically means that it's like covering half of each eye, and it's completely dark. You're not getting any visual information from half of each of the eyes. So if it would be the same half. And again, the eyes work, but the brain can't interpret any information from those. Visual agnosia. So visual agnosia is inability to recognize an object. So you see a hairbrush, you don't recognize it as a hairbrush, versus prosopagnosia, which is the inability to recognize faces. Now, if the stroke affects both sides, and especially remember, if you notice, the back of the brain and the bottom portion are all the occipital lobe. And so that does the eye movements and the interpretation of vision. So that's why your vision is so affected by this type of stroke. And so what can happen is if it's kind of a diffuse area that's impacted, the person, although their eyes would be working fully, may be diagnosed with cortical blindness, and that's the inability to interpret any visual input. So even though they're seeing things with their eyes, their brain doesn't interpret it at all, and so it's not useful information that they can use to navigate the environment. So it's cortical blindness. They would then respond like someone who has no vision because they have no input getting through to the brain and making meaningful vision. And then amnesia, memory loss, memory deficits. If the occlusion is proximal to the posterior communicating artery, there may be less effects because other areas may come in and supply those areas of the brain. All right, middle cerebral artery. Again, that's the red portion of the, sorry about that. So the red portions of this figure are the middle cerebral artery. And see how diffuse that area is. So a large area is going to be affected. It can affect the frontal, parietal, and temporal lobes and some of the subcortical structures. It can cause diffuse damage. It may lead to increased intracranial pressure. If that's the case, it may cause them to lose their loss of consciousness, to like pass out immediately. May cause a significant brain bleed, which could even cause death. So the middle cerebral artery can be very dangerous. And it's actually the most common type of stroke. And so you will be very familiar with the symptoms. If the middle cerebral artery on one side is affected, the weakness is on the opposite side in the arm, leg, and face. Typically, the arm is more affected than the leg. Again, looking at this portion here, the leg is more supplied by the anterior cerebral artery, but the arm, torso, face, all of that is supplied by the middle cerebral artery. That's why it would be more affected. And it typically will cause weakness and loss of sensation. Aphasia, if it's on the left side, remember left language, it would affect the language and cause some aphasia. Unilateral neglect, so typically they will neglect the side that they're not feeling, that they're not able to move or feel because they're not getting any input to the brain, so they'll forget that it's even there. Might run it into doors, might sit on their arm and not even notice, things like that. Anosognosia, that is the inability to recognize your own deficits. So that decreased awareness of what's wrong with what's really wrong. So maybe they have weakness in the leg, but they jump up to go to the bathroom without paying any attention that their leg's weak and fall down. Maybe they have weakness in the arm, but they go to grab something and are surprised that their left arm didn't show up. So that's anosognosia, difficulty recognizing your own deficits. And then apraxia and spatial deficits, difficulty, I put apraxia's definition somewhere, maybe I already did it, but with motor task, coordination and initiation of motor tasks. So it could be with arms and legs. It could also be with speech. Spatial deficits, especially if it's happened on the right side, like inability to recognize where you are in space, where your body parts are, or what your surroundings, to take that in and use it as useful information. And then homonymous hemianopsia, again, that's that visual field cut on one side of both eyes, so your brain is not relaying messages from those portions of the eyes. Isn't it amazing as we go through just what our bodies do, how our brain is made, and it's just amazing to me. Hopefully you're amazed by it too. It was an intricate design. Okay, if the basilar artery is affected, the basilar artery is right here, and it feeds the brain stem, which is the midbrain, the pons, and the medulla. There's a separate type of stroke for a brain stem stroke, but the basilar artery is one of the primary arteries that feeds that area. So some of the symptoms are ataxia, which is a difficulty walking, coordinating. It can be coordinating walking, coordinating balance, coordinating your speech, the ability to coordinate how to chew and swallow. All of that can go into ataxia. Vertigo, of course, that's dizziness, and balance deficits, and difficulty locating your brain or your head in space to know exactly where it is. Dizziness, and then bilateral deficits, difficulty coordinating movements from one side to the other. That's the basilar artery. With the brain stem stroke, typically it will affect the means for vital function. So your vital signs, your breathing, your swallowing, all of those things would be affected. So it could cause them to go into a coma. It could, really damage their ability to stabilize and be at a stable level, maybe in the ICU for a while, just depending. Decreased consciousness, and it would cause weakness on both sides of the body, may cause paralysis on both sides of the body. With the cerebellum, remember, cerebellum is mainly responsible for balance and coordination. So some of the things are dizziness, headaches, nausea, vomiting, ataxia, again with that motor planning, decreased coordination, double vision, tremors, and language deficits. One of the ways you can remember some of these is by that acronym VANISHED. So vertigo, ataxia, nystagmus. Remember, nystagmus is those jumpy eye movements. Intentional tremors, slurred speech, hypotonia, that weakness, exaggerated broad-based gait. So kind of like a baby walking when they walk with their legs apart and do kind of a fall forward with each step. And then dysdiadochokinesia. So that's those spastic, uncoordinated movements where they're doing kind of jerky, spastic movements. Thought just came up. Remember while we were at the one thing that was mentioned during the visit to the farm was clonus. So I just wanted to talk about clonus for a second. Clonus, when there is a upper motor neuron lesion. So upper motor neuron is talking about the brain. Lower motor neuron is let me get back to you. I think it's the spinal cord, but it might be the peripheral nerves. I think it's peripheral nerves. I'm going to specify in your play closet. I don't ever want to treat you or teach you the wrong way, but upper motor neuron, brain, and spinal cord. So anyways, clonus is a sign of damage to the upper motor neurons. So you quickly dorsiflex a patient's foot, and they should have two to three little beats. It should be, 5 at the very most. But if it just repetitively shakes after you quickly dorsiflex it, it just shakes, that is clonus, and it is a sign of an upper motor neuron lesion. All right, with locked-in syndrome, this would be a stroke of the vertebro-basilar arteries. And it's a very unfortunate event because it causes paralysis of all muscles except those controlling eye movements. Now, sometimes facial expressions might be possible as well, but speech is not possible, and active movement of the arms and legs is not possible. So the person is alert and aware of everything going on, but not able to move or to speak in order to interact with their surroundings, with people around. And the life-sustaining activities are intact, so you're able to breathe on your own and have all those functions, but it's similar to being awake in a coma. You're stuck in a position. That's why it's called locked-in syndrome, but your alertness is there. Now, this girl in particular, I saw some articles on her that she, since having locked-in syndrome, has gotten a college degree, and this is a speaking device that she's able to use. So I'm not sure how it works, if she just does different eye movements and it picks things, for her, messages for her to relay. But it's just amazing, what technology is out there to help someone, with advanced disorders. All right, assessment techniques. So these are different scales that we use to assess a patient with a stroke. Typically, the PT will do it during an eval and then record those values and use that to show progress and to meet the requirements of insurance and things like that. So modified Ashworth scale primarily measures the spasticity. The Fugel-Myers scale assesses their impairments. The motor assessment scale assesses your activity limitations. Stroke impact scale is a questionnaire to determine how the deficits impact the patient's life. And then the modified Rankin scale is a disability scale. Any of these can be used. More than anything, it would be important for a PTA to know how to interpret the results of the scales, but not necessarily how to give any of those assessments. So just kind of be aware of what they are. Treatment techniques roadmap. So these are some of the things we're going to go over with how you treat a patient with stroke, some of the techniques. We're going to spend the most time on PNF, and then we'll go through NDT, Brunstrom stages, and Swiss ball. All right, so neuroplasticity. Plasticity, most of our treatment gains in stroke patients come from neuroplasticity. Neuroplasticity is the brain's ability to reorganize neural pathways. Once you practice an activity repetitively and do it over and over, your brain is actually able to increase the number of synapses on a neuron. And so areas that weren't being active can create new pathways to go to an active part of the brain and start receiving stimulus again. Just like plasticity of the muscles allows you to grow the muscles to a stronger, larger size and become more efficient. Plasticity in the brain allows new pathways to develop to allow functional use in areas that may not have been previously useful. One of the primary areas for neuroplasticity is in the definitions kind of at the end, and it is the penumbra. It's the area around the ischemic core. So the ischemic core means that this red portion is the core where those cells have died. They're not coming back alive. The yellow portion was damaged, maybe due to inflammation or some lack of blood supply, but there's an ability to reconnect those synapses and for the neurons to reinnervate and make new pathways to be able to give you more function. So that's just an amazing thing that our brain can do to give us function back. All right, so with proprioceptive neuromuscular facilitation, PNF, it's an approach used to evaluate and treat neuromuscular dysfunction by facilitating sensory motor integration during functional activity. So what it does, it uses proprioception, which is your sensory input. That is afferent, coming from the skin, going to the spinal cord and brain, in order to stimulate a motor response. That's efferent, going out to your muscles. So PNF uses the afferent pathways, your input, sensory input, to create and activate a response through the efferent or motor output towards the muscles. So we do a technique where we, have our hand placed a certain way and we do a quick stretch or a movement that's supposed to help elicit a response from the muscle. Some of the concepts, the focus is on the body position, the manual contact, so the therapist will have their hands in specific places, some to activate a muscle, some to inhibit the activation, applying appropriate amounts of resistance based on the goal and the patient's abilities. Traction and approximation, so portions of it are pulling the joint to a more open position, or other parts are pushing it to a more closed position. Remember, approximation is like that deep impact, and a lot of our proprioception and our neuromuscular, our input, our feedback sensation comes from the receptors in a joint. So approximation is important on reintegrating those pathways. A quick stretch. So a quick stretch is typically used if I want somebody, let's say, to be able to extend. They're stuck in flexion and I want them to be able to extend. Whenever you do a quick stretch in one way, in one direction, remember your body elicits a response to push against you in order to protect the body from injury. So if you do a quick stretch in one direction, automatically a reflex will push against you. So you push them in the opposite direction to activate the muscle that you want them to go towards. So you do a quick movement in the opposite direction if I want to go towards extension, and then you do a slow movement towards extension. to help inhibit the biceps and activate the triceps. And then verbal and visual stimulus is given as well in order to create the best activation possible for the patient. PNF patterns are broken down into upper and lower extremity, D1 and D2, and flexion and extension patterns. So we will go over those shortly. The approach, it's an integrated approach. It looks at the whole person and the function of the person, not just one injury or problem area. It's a positive approach. You use the patient and you reinforce the patient's abilities and mental and physical capacity. So you're trying to get them to their highest level, and the goal is to achieve their highest level of function. Some of the principles. So there are 6 principles of PNF, ways that they target a muscle activation and functional use. Now, there's a video below that goes over these in depth, and I really think it would be helpful actually in understanding properties used for electrical stimulation. So you might want to watch the video even for that. But after discharge, that's a lasting effect of stimulus after the stimulus is removed. So think about interferential current, IFC. It has that kind of tingling sensation, and after, if you have it on for 15 minutes, you take it off, and typically the effects, the decreased pain, last for 15 additional minutes. That's after discharge. So you've already turned off the machine, removed it from the area, but they still have lasting nerve impulses and effects on the stimulation. Temporal summation. So if you have little small stimulus that may not cause a response, but you have them frequently over a short duration of time, so many high frequency stimulus, then it produces a larger effect. So you're on one nerve, one area, and you're going very quickly to try and elicit a larger response. So like tapotement kind of goes by that principle. We tap on a muscle quickly to try and activate that muscle. Spatial summation. Again, summation is adding together the impulses. So spatial summation, you're touching or stimulating different areas in order to combine that for a greater response. So rather than just being on one area, you have a diffuse area that you are putting input in several areas that kind of go to the same synapse in order to create a larger response. That is spatial summation. Irradiation, that's an overflow of energy from stronger to weaker muscles. So in the video, he gives you an example of unlocking a jammed lock. If you're unlocking a regular lock, all you have to do is pronation or supination. You just have to turn the wrist. But if the lock is jammed and hard to do, rather than turning the wrist, you'll get the forearm muscles, you'll get the shoulder muscles, and you may even lean your whole body into it and activate the trunk in order to use the strength of those big, strong muscles in order to assist with the movement of that smaller muscle group. So it's an overflow of energy from larger muscles into the smaller muscles. That is irradiation. Successive induction is once the agonist is fully fired, then the antagonist muscle begins to activate. It kicks on. So if I get my biceps in full flexion and it has nowhere else to go, there's kind of a stimulus sent to the triceps saying, all right, we're done here, and they kick on and are able to activate better once you start in range from the other motion. And then reciprocal inhibition, we've talked about it before, is while one muscle or the agonist is being excited or activated, the antagonist is being inhibited or kind of in a rest period. That's called reciprocal inhibition. While my biceps is activating, the triceps should be relaxing. That's to try and decrease that co-contraction of muscles. All right, so let's go through what the PNF patterns actually are. So there's a video below. Right here is the link, and it goes through the patterns and shows you and tells you kind of how to cue your patient on how to do the patterns. It's It's one thing to know how to do them yourself, but it's another thing to teach somebody else to do them. So I definitely recommend watching that video so that you can understand these patterns. But the basic patterns, D1 flexion, you can start. The patterns are named based on the action of the proximal joint. So if the shoulder is going towards flexion, then it would be called flexion. If it's going towards extension, it would be called extension. And the same for the leg, it would be based on what the hip is doing. So D1 flexion, we start with a straight arm, and we're naming it based on what we're going towards. So we are going towards flexion. The upper extremity is flexing, and it would be kind of like throwing a scarf over your shoulder. You grab the scarf from the towel rack, coat rack behind you, and you throw it over your shoulder. Versus D1 extension is the exact pattern in the opposite sequence. You start in the flexion and you grab it and you throw it behind you. So the kind of visual we say is somebody taking off their earring and throwing it because they're getting ready to fight. So D1 flexion, you start behind and you throw the scarf over the shoulder. D1 extension, you grab your earring and you throw it behind you, ready to fight. Versus D2 flexion. So we start at the opposite hip and we throw over our head. So we start across, kind of in a more extended pattern, extended pattern of our shoulder, and we're going towards flexion. It's like taking a sword out of a sheath. So you grab your sword and you throw it behind you. Watch out, people in the back. Or you unbuckle your seatbelt and you put it back. Versus D2 extension, you kind of grab your seatbelt and pull it to buckle it in. Or put your sword back in. Grab your sword from the guy behind you and put it back in your sheath. That's D2 extension. So D1 is the scarf or earrings, the accessories, and D2 is the sword or the seatbelt. Okay. There's also scapular PNF patterns. So one is anterior elevation. The most common are anterior elevation and posterior depression. So you're coming up and forward for anterior elevation, down and back for posterior depression. Now you could do anterior depression and posterior elevation, but it's really just not as functional. So we typically do anterior elevation, posterior depression. For the legs, we also have D1 and 2, and then anterior elevation and posterior depression. So with the legs pattern, D1 flexion, it goes from lower extremity abduction and extension to adduction, flexion, and external rotation. This is the leg. I'm just showing you with the arm because, you know what, I can stand up and show you with my leg. So it's kind of that Peter Pan pattern. So we start out with our leg behind us and in abduction, and then we come up and in. So it's like the Peter Pan leg, from down, back to up and in. Okay, and then D1 extension is the exact same, but in the opposite pattern. Start up, kick back, up and back. D2 flexion starts from the leg straight and externally rotated and go towards the dog peeing on the hydrant. So you start out forward and you go out and back. Forward to back. D2 extension is the exact opposite. You start in that peeing pose and go towards the lower extremity being more extended and externally rotated. So this is going towards D2 flexion, towards D2 extension, towards D1 flexion, towards D1 extension. Now the pelvis, the anterior elevation, goes up and forward, posterior depression, down and back. Anterior elevation, up and forward, and posterior depression, down and back. And that actually mimics what our pelvis does during gait. So we typically always use that for the pelvis, anterior elevation and posterior depression. The others are there for reference, but aren't typically used because they're not as functional. benefits of PNF can help you increase relaxation, decrease difficulty initiating movements, increase coordination, increase strength, decrease joint stiffness, decrease fatigue, decrease pain. Now, everybody that I know that really use PNF was certified in PNF. I would highly recommend, if you're going to use it a lot, especially if you're going to work with a lot of neurological patients or even pediatric patients that have neurological deficits, I would highly recommend getting trained and certified in PNF, because your hand placement, the amount of force, the speed of movement, all that is huge in what you're activating. However, you can use those patterns, because basically those patterns have been found to be very functional. You can use those patterns during your passive range of motion, during your strengthening, during whatever, and you can use the kind of the principles of PNF to enhance all of your treatments. But if you're really truly using PNF techniques, I recommend getting certified in PNF. All right, so NDT. NDT is where a PT or PTA manually assists a patient through movements with emphasis on their hand placement, so similar to PNF, to increase activation of specific muscles. So they're basically teaching the patient, helping them, the focus is on relearning normal movement patterns. So they're trying to use both sides of the body and trying to limit their compensatory muscle activation. So if somebody, usually when they're reaching, a normal reach just looks like that, but they're reaching and they're bringing their whole arm up, then you kind of block that movement and facilitate a normal movement in order to relearn the normal movement patterns and decrease additional muscles from activating. What they're trying to do is that summation that we talked about. I'll remember the word, irradiation. They're trying to do the irradiation, where they bring in other muscles to help provide strength for that weak muscle. But as you're strengthening the weak muscle, you need to now decrease that compensation so it can be a more normal pattern. So common things that are used in NDT are weight-bearing activities, especially on the upper extremities, legs as well, trunk positioning and stabilizing. So you're working on trunk stability and distal mobility. Remember, CCDD, control centrally, direct distally. So trying to get the trunk more stable so that they can free the extremities to do what they need to do. And then functional tasks, but blocking their compensation. So this activity is great. She's weight bearing on the hands, then freeing a hand to put a ring on a cone. And that's a functional task, plus it's weight bearing, plus she's having to use her core to stabilize. So that's a very good example of NDT. The Brunstrom stages of motor recovery. So this is after somebody has had a stroke or brain damage or anything, and they typically go through a pattern of recovery where they start out flaccid. Everything's weak and it's just hanging. This is an example of a flaccid arm. Typically it's adducted and depressed and kind of hanging towards midline. And no functional use. The hand is typically kind of in more of a claw pattern. Then as they begin to progress, they'll start to develop spasticity. So more of that upper extremity synergy pattern we'll learn about in the next slide. And the spasticity actually gets worse before it gets better. But the spasticity getting worse is a sign that they're improving, not that they're declining. So please know that you'll definitely be tested on that, because I don't want you ever to tell a patient that their condition is getting worse because their spasticity is getting worse. It may actually be a sign that it's improving, that their brain is healing like it should be. And then with the next stage, stage 4, they begin to have some movement away from the synergy. So if in stage 3, they're basically stuck in that pattern, in stage 4, they can reach away from that pattern, but then it pulls them back and they rest in that spastic pattern. With a stage 5, they begin to have active movement isolated from the synergy. So they may be able to break through the synergy, do a full functional task, but then they'll kind of go back towards the synergy. So they're able to break away and isolate and do movements away from the synergy pattern but they still have some spasticity pulling them towards that synergy. And then in 6 is when they start to break through that and have near normal speed and coordination. So basically at this point, they're doing functional tasks. They're even able to hold their arm in a resting position away from the spastic pattern, but the tasks are still a little shaky or a little compensatory. They're using other muscles. It's not quite the full spectrum of a normal task. So they may have some type of different pattern they use or compensation or shakiness. And then of course 7 is when they're back to normal movement and ability to do the movement with good speed, accuracy, and coordination. All right, with the Brunstrom Synergy. So typically there are extension synergies and flexion synergies. With all things, as we've talked about before, flexion typically dominates. When you get a contracture, it's towards flexion. When you have spasticity, it's towards flexion. That typically dominates. But there are some cases where it might be more of an extension synergy. So with the extension, the shoulder would be depressed and protracted. So retraction is back, so protraction is forward, adducted, internally rotated, elbow flexed, forearm pronated, wrist extended, fingers flexed. Okay, so this kind of pattern. All right. With the shoulder flexion, the shoulder is elevated and retracted, abducted to 90 degrees, externally rotated, and hyperextended, elbows flexed, forearms supinated, wrist is flexed, fingers are flexed. So it's kind of like making a big muscle there. But with the hemiplegic arm, it does its own thing. Shoulder is adducted, elbow is flexed, forearm is pronated, wrist is flexed. So right there is kind of our typical hemiplegic pattern. And you'll see that same pattern in children with cerebral palsy and other things as well. So it's not just with people who have a stroke. And then the lower extremity synergy, the extension typically dominates. Hip extension and adduction, internal rotation, knee extension, ankle plantar flexion. So everything is fully extended and the toes are pointing down. With the flexion, lower extremity flexion, you go towards hip flexion, abduction, external rotation, knee flexion, ankle dorsiflexion. So it's kind of like that Peter Pan position. Everything's kind of pulled up and externally rotated. With the hemiplegic leg, typically the hip is flexed and adducted. The knee is extended and the ankle is plantar flexed. So sometimes it'll even cross midline. So towards that extension pattern. All right, Swiss ball training, you'll also hear it referred to as the TheraBall or therapy ball. And anytime you're using an unstable surface, it's going to increase core activation. This challenges the core, helps build core stability, and improve sitting and standing balance. It also will improve the ability to perform functional tasks. If you're more stable centrally, you're going to have more control distally. So putting a patient on an unstable surface is a great idea, whether it's a swing or a horse or a ball or Bosu ball, even cushions, whatever you can get. But the Swiss ball is what we're going to talk specifically about. Some of the common treatment activities that we would do are having the patient sit and do upper extremity reaching activities. Often with young kids like this, I would have them sit and I would tilt them to the side like that, so they would have to activate their core muscles to hold themselves up, and then I would tilt them to the other side. You may even tilt them towards the front and back. Having her look over her shoulder also increases that rotational strength, so that's a great activity. In this next picture, weight bearing on the arms over the ball, so that can help activate the core muscles and strengthen those while also getting that proprioception. And I typically did have, for my children at least, a reaching task, go towards this toy on the ground, pick it up and put it in this bucket, something like that, to increase motivation. For an adult, they may just walk out and back, but you have to be a little more careful with adults because it's harder to control the weight And if they just get barely off balance, then they'll slide off the edge of the ball. So just be a little bit careful with that. You can do seated marching. You can do pelvic tilts each way, forward and backwards. You can do sitting balance with your eyes closed, and then lateral trunk leans, as I mentioned earlier. Treatment activities, so other activities that you can use specifically with stroke patients. So looking towards the affected side of the body when they have that neglect and low awareness of the side of the body. I mean, they're not getting visual input, possibly, depending on the type of stroke. They're not getting sensory input. If they're not able to also use motor output to that arm, then it's just setting them up to ignore that side of their body. What's it there for if they can't use it? So they're typically looking away from it and everything. So getting them to look towards that side of the body, even to, touch and feel that side of the body, deep pressure on that side. Oftentimes putting a mirror in front of them and having them look towards that side of the body and touch it in the mirror can help increase their awareness and their use of that side of the body. Strengthening the weak side, you can do gait training, balance training, all of the same things that you could do with anybody who has leg weakness or balance deficits. Another thing I didn't put in the slide, but something that's really interesting, constraint-induced movement therapy. That's actually one of the things that got me interested in physical therapy. I wrote a paper about that in undergrad, about how you can actually, let's say they have a stroke and weakness on the left side, you can constrain the stronger side and put it in, typically they use like a mitt, sometimes they'll even use like a shoulder sling, something like that to keep it from working, to push the patient to use that arm more. But also when the brain is tricked into thinking that there's damage to the stronger side, then it creates more pathways in a more efficient way to the damaged side. And so constraint-induced movement therapy, the true method is to put the constraint on and do like 6 to 8 hours of training per day for like 2 weeks straight. And they've seen all kinds of benefits, within a few months after someone has a stroke, pushing them to they do functional reaching and grasping and manipulating objects, a lot of fine motor tasks while wearing the constraint and only using the weaker side, and their brain really develops these pathways to kind of increase their function. All right, daily activities as treatment. You can use anything that they typically do as treatment. Pouring activities, carrying a tray, carrying a cup, wiping a mirror, reaching for objects, anything that they typically do. It helps. What your focus is not, getting a cleaner mirror or giving the patient something to eat, but the focus is increasing their independence, increasing their speed, their accuracy, their coordination with the activity, and decreasing the compensation. So you'll provide cueing and feedback and possibly tactile stimuli to try and decrease the compensatory patterns and increase the correct muscle activation. This can benefit range of motion, strengthening, dexterity, coordination, by manual tasks. This can benefit with connections between the two sides of the brain, amazing things, and the patient's typically more motivated to do it. Functional activities and daily activities both increase the patient's compliance. They're more easily understood by the patient. Oftentimes, if you just hand them a cup or a spoon or whatever, they kind of revert to these typical patterns and are able to use it without instruction. So if somebody has difficulty processing and following instructions, you can just hand them a hairbrush, and they may start brushing their hair, just based on past experiences and memory of that tool, versus you saying, now lift your arm, now rotate backwards, now pull down. I mean, they can't follow those instructions. So it's more easily understood and more likely to be practiced in the home exercise program. So for example, if you're wanting to strengthen the bicep in a functional way, you could just hand them a water bottle and have them take a couple drinks, rather than just giving them a weight and having them do bicep curls, especially somebody who has low awareness of their deficits, low body awareness, amnesia or difficulty with, memory, processing, any of that, it's going to be a lot more difficult for them and less motivating for them to use just basic weights. All right, so a few definitions we're going to go over in understanding some of the terms used in patients who have had strokes and other conditions as well. So infarction is an area of tissue dies due to hypoxemia, so low oxygen flow, after blood flow is stopped. So the area, blood is not getting delivered to the area, there's not enough oxygen, and the cell eventually will die. Necrosis is what it's called, cell death. If it happens in the heart, it's a myocardial infarction, heart attack. If it happens in the brain, it's a stroke. Hemiplegia is paralysis on one side of the body. Hemiplegia. Hemiparesis is weakness. Just remember the difference there. Spasticity, velocity-dependent resistance to passive stretch. So if you slowly stretch, then it may not be as present. If you do a quick stretch, it's more present, more spastic. Typically, spasticity is more rigid and tremoring and what we call cogwheel, where it lets you go little. Versus tone is resistance to passive stretch. Like, for example, in your hamstrings, you get to in range and it just stops. There's tone there that stops it, but it's not a shaky stop or resistance throughout the movement. It's just you get to in range and there's a stop. And that's more because of viscoelastic and reflexive mechanisms rather than from input from the brain. Flaccidity, we've talked about, is the absence of muscle tone. A lesion is just abnormal brain tissue due to an injury. So the area that's affected by the stroke would be the lesion. Some people call it a brain lesion or spinal cord lesion, depending on what's going on. The number we talked about, area around the core that has not died but been affected by the injury or the condition, and is the best area for neuroplasticity. Apraxia, we talked about earlier, motor disorder. It makes it difficult to produce purposeful movement, including speech. So apraxia, it's going to be hard to walk, hard to carry objects, anything purposeful. It's hard to coordinate those movements. Agraphia is just difficulty with written language. So they may be able to hear and understand speech and make speech, but not be able to read anymore. Somatognosia. Somatognosis. I'm not getting it right, but somatognosia is what I'm calling it. Inability to recognize one's own body parts. So inability to realize, yourself and others actually, what things are, what your hand is, what somebody else's hand is. Anosognosia is that misunderstanding of your own condition and decreased awareness of your deficits. We talked about earlier, common with right hemisphere deficits and with middle cerebral artery deficits or stroke. TIA, transient ischemic attack. Some of you all have probably heard of that referred to as mini strokes, and that's essentially where there's a temporary block of an artery that's resolved within a few minutes. So there might be a clot. The clot kind of breaks up and goes down two different areas, and so it doesn't fully create lasting effects. So for a few minutes, the patient has symptoms of a stroke, and then within a few minutes they resolve fully and they go back to their normal function. And anybody who's having mini strokes or TIAs is at a high risk of having a stroke, because it tells you they have blood clots. There is some plaque or buildup that's causing the blood clots to not get through, and they're likely to have one get stuck and cause a stroke. All right. Last three things we're going to talk about. Aphasia. This is acquired language disorder. Could be related to inability to name objects, inability to find words. You see, I have inability to find words all the time. And it results from brain damage. So there's two primary types of aphasia: Broca's aphasia and Wernicke's aphasia, which are based on the area of the brain that is affected. I meant to put a picture on here of that, but Broca's aphasia, the patient has difficulty producing speech, so unable to put the words together and make fluent statements. So it could be that they're like, I want, and then they can't think of the word. Or it could be that they're, making noises. Like I had one patient that would just go pa, 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 pa. That's all he could say. And he would be like making a sentence of pa, but it wasn't the word he was trying to get out. He would get so frustrated. That's Broca's aphasia, so an inability to produce speech, versus Wernicke's aphasia is the difficulty with comprehension of speech. It could be written language, it could be spoken language, it could be both. Reason it's called fluent aphasia is because they can speak and produce speech, but they cannot understand the verbal cues you're giving. And definitely with patients like this, you want to decrease your verbal cues, use tactile input, use visual feedback demonstrations with as little verbal cues as possible, because it will just be confusing. Now, the speech therapist may say use the verbal cues, especially when they're in a stage of recovery, because it might help reconnect and help them learn, but it would still be like short cues. So rather than saying, next, I want you to lift your arm up and reach towards your head, you might just say reach up or arm up, and just really short, 2-word or less, 1 or 2 word responses if possible. And then global aphasia is both difficulty making and comprehending speech. Pusher syndrome. So after a stroke, some patients will develop pusher syndrome, which causes them to push towards the weaker side, which is pretty bad because then they may fall over. They may not have the strength to actually hold themselves up. It causes balance and postural deficits in sitting and standing. Patient cannot find midline, even if you put one of the treatments we use is actually putting a mirror in front of them with a line in the middle of it so that they can see I'm over on this side of the line and now I need to get up and be in the middle of the line. But very hard for them to locate midline and to get themselves aligned. So when they're pushing towards that side, they feel like they're upright. And when they're upright, they feel like they're falling towards the stronger side. Now, the stronger side is getting all this input and the weaker side is not, which is one reason they are pushing towards that side, is because they're only getting input from one side. So it's kind of like an uneven input being received. And it typically resolves itself within 6 months, but with therapy, it can resolve more quickly and cause less damage, like falls, things like that. And Wallenberg syndrome. So this is a stroke in the nuclei, lateral nuclei, which creates a vestibular storm. So patient pushes to the strong side with Wallenberg syndrome. So if it was on the right, they would now push towards the strong side. They have vertigo, dizziness, balance deficits. Their eyes will typically roll towards the affected side. Often the eyelid will droop, and the pupil will be smaller on the affected side. They also have decreased sweating on that side of the face. Their speech will be slurred, their vision doubled, and that is all related to a stroke in the lateral nuclei. It could be called a lateral medullary syndrome or posterior inferior cerebral artery syndrome, which is referred to as pica syndrome. You'll probably hear it referred to as that in hospital settings oftentimes. Okay, that is the end of our lecture on stroke. I hope that you were just as amazed as I am about what our brain can do and how our body is able to compensate and create new pathways to allow us to do something even if a portion of our brain completely dies. If you have questions, please let me know, and I will see you in class in lab.